And welcome. We're going to begin our hearings today in Senate Health and Human Services. And before we do, I'm going to ask Senator Long to lead us in the Pledge of Allegiance. Okay, before we get started, I'm going to I just need to make a couple of announcements today. This is a very busy day for us here at Health and Human Services. This is the last day that we're going to be hearing bills. We have one more day before we have to get our bills out of committee. So we are under a lot of pressure here to get that done. We've got 5 bills, which is a very aggressive schedule. I understand that, but in respect of time, I'm going to ask anybody testifying today for any of our bills. The prime sponsor will be able to introduce the bill. We'll take testimony from any departments that are here, and then testimony from the public will be strictly 3 minutes, and that will be strictly enforced. So a couple things on that. If you're here to read testimony, we can all read. So feel free to just submit your testimony and our staff will get it to us. I will stop you if you're reading testimony and ask you to summarize your points on that. When the timer goes off, you'll hear the timer and you'll be asked just to finish the sentence that you're on. I know that can be a little abrupt sometimes, but again, we all have to be out of here at noon we all have other meetings this afternoon and we have to get this through this agenda. So with that, I'm going to ask Senator Prentice to, Senator Avard, my vice chair. Oh, look at that. You almost had it, Senator.
You haven't started yet, huh?
We're started right now. You're going to run the show because.
Y'all did the pledge and everything?
We did.
Wow. I get to sit in the big man seat. Oh, it's nice and warm. Actually, I shouldn't sit here. So we're going to open up the hearing for SB 504 and hear from our prime sponsor.
Hey, thank you, Mr. Chairman. Thank you, committee members. For the record, my name is David Rocher. I represent Senate District 1. And before you have Senate Bill 504. And this is a comprehensive bill. It's addressing 80% of it, I would say, is addressing things that need technical corrections. It's cleaning up stuff that maybe had been passed in the past and we missed some things. But I just want to go over some of those things so we understand what it's doing. And you can see on the introduction, there's 6 bullet points that it does. I just want to dig into that a little bit in respect for time. And I'll go through those as they are presented in the bill. So first off, we have page 1, line 3. It will allow the dispensing of a 30-day supply of a non-controlled oral anti-cancer medication by a licensed healthcare professional legally authorized to prescribe that. The basis of that is and we've been hearing about this for a couple of years, but we have instances where we have oncology clinics that evaluate a patient, they determine the appropriate treatment, what the appropriate treatment is, and they have the ability to dispense that treatment at the time of the appointment, and the law doesn't allow them to do that. So the reason why we put that in there is we don't want any delay in therapy for these folks. These are things that are, in many cases vital to begin a chemotherapeutic regimen, and we want to make sure that they can get the medication they need when they need it and get started on it right away. And this would, by doing this, they would speed up the process of availability of drug, prior authorization, all the things that sometimes we have to go through in a community setting. It would allow the clinics to actually do this and get therapy started right away. Page 1, line 10, just a cleanup. Traditionally, you had one pharmacist working in one pharmacy, and the law said the license had to be displayed at that pharmacy. But the reality in today's world is that you may have a pharmacist working at multiple pharmacies floating around the state. In fact, I was at my local pharmacy the other day, and the person drove up from Nashua to work that day. So rather than having to post this license around every location that they work at, it's just changing it, from conspicuously displayed to be readily retrievable. And I want to add to, since this came, this has been on the books for many, many years. But what the state has done is you can actually verify licenses online now instantly. You go on OPLC's website, find out if a pharmacist is licensed, and the board often will check that when they do an inspection. But this just changes it from conspicuously displayed to readily retrievable, a reflection of the modern times that we're living in. Line 21, we added a position of licensed advanced pharmacy technicians to our law a few years ago. And this is just a section where we authorize remote work for a variety of professions. It was missed when we passed the law that we would allow licensed advanced pharmacy technicians to engage in remote processing. So what remote processing is, I look at like Amazon, for instance. They have a facility in Manchester, but they might have their pharmacists and technicians, believe it or not, working around the state from home, and they're processing the prescriptions, not filling the prescriptions, but they're entering the data, doing the drug utilization review, stuff that doesn't have to be in a brick and mortar pharmacy. This just makes sure that the LAPTs can do that remotely as well, adds some clarity. Page 1, line 26, a number of years ago, we changed the law so that the initials of the dispensing pharmacy doesn't have to be on non-controlled substances. And the reason why is there may be several pharmacists involved, and our computer technology can track each pharmacist, each stage of the way that they fill a prescription. So we have an electronic record of that. So a number of years ago, we eliminated that requirement that a pharmacist's initials have to be on the prescription, because quite frankly, it's not really reflective of the way a prescription is filled. We didn't do it in 318B. So we did it in 318. We didn't do it in 318B. It was an oversight at the time. So this just gets that law, gets that in line with that. I am going to skip ahead a little bit because I think one of the ones that we have a lot of questions on, I want to hit that last. Page 2, line 28. So we have in the state law that sets up collaborative practice agreements. So a collaborative practice agreement is an agreement between a physician and a pharmacist, and it's often used to deliver care. So we've got facilities in the state that manage high cholesterol patients, manage blood pressure patients, and the pharmacist is actually doing that work, and it's done on a protocol. The physician has the liability there, but it's a matter of trust between the pharmacist and the physician. And what these line 28 through 37 do is it says, if the pharmacist is good or the physician is good with this arrangement, and the pharmacist is good with this arrangement, and the physician is comfortable with the pharmacist's level of knowledge, and they're the ones taking the liability for this, the way the law is written, it says the Board of Pharmacy then can add additional requirements on top of that. And having been on the Board of Pharmacy for a number of years, I just feel like that's a relationship between the physician and the pharmacist. And again, the liability is on the physician. Why does the Board of Pharmacy need to add further hoops to jump through with that? So we've added that. That's there. And then there's an amendment that you have. We're going to talk about that. Amendment 0862. So I got my pharmacy license 28 years ago. And at the time, you take a clinical examination to determine whether or not you understand the clinical aspects of pharmacy. It's a national exam. It tests you all on your pharmacy knowledge that you learn in school, and it's your board exams. And every year, or every 2 years now, we have to continue our education in the clinical aspects of pharmacy to ensure we're up with new therapies, emerging treatments, changes in practice. And we have to do that every 2 years in order to get our license renewal. Pharmacists are also required to take what's called a jurisprudence exam, a law exam. And talking to OPLC, there are a few professions that require this, but most professions don't. And I think it's appropriate now to eliminate that requirement, that the exam requirement. And I'm going to tell you, in my case, I got my license in 1997. I took the jurisprudence exam and I never had to take it again. And we all know that laws and rules have changed dramatically over the course of those nearly 30 years. I am still held to that standard of whatever is the law today. I have to make sure I'm compiling the law. But the exam I took was on the law 30 years ago. Many states are doing away with the jurisprudence exam just because the mere fact that it's not reflective. It's reflective of a moment in time, and there's no obligation to continue that education in law and in legal practice in New Hampshire. So I think New Hampshire is poised right now, like other states, to eliminate that requirement. They're still required to know the law and comply with the law, and if they don't, they're going to be in violation of the law. But several states, and I anticipate this would happen in New Hampshire if we pass this, you do an attestation. We do an attestation every way when you renew a license, and that would be covered with that. Vermont was the most recent state, as I understand, to eliminate that. And then going back to the licensed advanced pharmacy technician, this bill was passed, like I said, 3 or 4 years ago. It added a new scope of licensure, and it allowed the Board of Pharmacy to do certain things. The Board of Pharmacy, I was on the Board of Pharmacy at the time, instituted an examination in order to get this licensure. And I received a couple of complaints. The licensure has been in place for a number of years. The exam has been in place. We're starting to get some folks licensed under this designation, but I had some complaints from the community. And the community was, the exam that we have to take is not reflective of the scope that we're doing. In fact, the exam is far more reaching than what we're allowed to do by law in the state of New Hampshire. So I called OPLC and I said, can I get a couple of exam questions? I just want to validate this to see if this is true. OPLC told me that we don't administer the exam. The exam is administered by a national group, the National Association of Boards of Pharmacy. And like our clinical exam is done, our board exam is done that, our boards are done that way. So I said, well, not a problem. So I reached out to the National Association of Boards of Pharmacy in my official capacity as a senator, as the chairman of Health and Human Services, and I corresponded with them and I said, I just want 10 to 15 questions. I just want to make sure that the questions are reflective of the scope. And I said, I'm willing to sign any NDA that you need. They refused to give me the questions. So if they're refusing to give me the questions, it's telling me, there may be some validity in what they're saying. So, I think when the legislature put this licensure in place, there were a lot of guardrails already put in this place. I think that, and I don't necessarily disagree with the exam per se, but if we can't we as the legislature who hold the licenses of these individuals can't even see what they're being tested on, and they refuse to give us the questions, just an example of questions, I think that's a big red flag, and it's time for us to go back to what the original legislation was. I think those are the easy things. Those are the things I think that, you know, a lot of the questions have been answered. We're gonna be hearing testimony from a number of folks today about page 2, lines 5 through 23. And this is the definition of the practice of pharmacy. So if you look at the definition of practice in pharmacy, the way I've structured this in the bill, just format wise, it clarifies, it puts it in bullet points. It's not a long narrative of what the scope of practice or the practice of pharmacy is. It puts it into a bullet point format, so we know what it is. It clarifies that. It's in line with the other, the things that we've traditionally been doing. But if you look at page 2, line 17, the word that I've added in this bill is prescribing. And I think we're going to hear testimony that a number of other states, I think over 20 states, have that word in their definition of the pharmacy, the practice of pharmacy. There are states that are prescribing, allow pharmacists to prescribe at will, if you will. The one that comes to mind is Idaho. They have full prescriptive authority, despite the fact that there are over 20 states that have this word in their definition. They are actually using pharmacists as primary care providers. They have a very defined scope that they're doing it in. In speaking with folks from Idaho, there isn't a lot of uptake with that. The pharmacists, if we were to do this, they're not allowed to prescribe things like controlled substances already in the state of New Hampshire, even though some states allow that. But the feedback I've heard is, what does this word mean? And I went back to the pharmacy community and I said, listen, I know what my committee is going to be posed, what kind of questions are going to be posed to the committee. I know what questions are going to come before us. We're going to take this time, I think, this morning there's people from the pharmacy community and really understand what that means. I don't want pharmacists to be opening medical practices on every corner in the state of New Hampshire. That's not the intent. But I think there are some instances, the way pharmacists are trained, they are trained in diagnostic criteria. They are trained in prescribing. We do see it in these collaborative practice agreements. So I think there's an opportunity here for some discussion about that and see how we can utilize pharmacists to their abilities, to what they're trained on, to improve access to care in New Hampshire. I do want to point out, I'm going to close right now really quickly. And I think this underlines a movement in pharmacy in general, and I think this is going to start the discussion here in New Hampshire. Pharmacy is a rules-based practice. We have rules that tell you what you can do and rules that tell you what you can't do. And it really reads like an instruction manual. And in fact, if you look at the rules and laws in the state of New Hampshire for pharmacists, there are more rules and laws for pharmacy than there is for nursing and medicine combined. And the difference is, in medicine and dentistry and in nursing, they operate under a standard of care model. So you're trained to do this. You can use your knowledge to treat patients, and you do what's within your professional capabilities. Pharmacists are trained in that model now, but the way the way we have it right now, it's a rules-based approach, and there's a trend around the country to make that shift. I understand some of the questions around that. And I think we have an opportunity here to start that in New Hampshire. So with that, I'm happy to answer any questions. Otherwise, we'll get
questions from the committee. Senator Britzel.
Thank you. Thank you for taking my question. On the amendment,
yes.
The only question I have in line 10 through 14, where it says applicants for licensure as pharmacists shall, to prove their respective requisite knowledge, be examined to a properly varying degree in pharmacy-related subject areas, may include chemistry. You're not allowed, it says here, you're not, they can't be examined. What other ways do they test to make sure that the pharmacist has knowledge of jurisprudence and law?
So one, I mean, pharmacists, when you get that license, you are required to comply with everything in the rules and laws. I mean, that is a requirement of a licensure. I didn't know that was the law. I didn't know the legislature changed that. That's not an excuse. And it's not an excuse for any profession that doesn't have a jurisprudence exam. So the same standard applies to both. So when I took the exam 30 years ago, the law was very different. And I knew what you're tested on the law for that particular moment in time. So pharmacists, despite the fact whether there's a jurisprudence exam or not, on day one of your licensure, they're required to understand, know, and follow the law by standard, by practice, by licensure for the extent of their profession. So that's one guarantee that we have, that they're required to do that. And if they don't do that, there's ramifications for that. So the other question, the other part of the answer to that question is pharmacy law is taught in every school in the United States. So they are getting pharmacy law as a part of their education. It changes various things in different parts of the state. And I would add that this is they do again have to comply with the law whether they have to take an exam on it or not, just like dentists do, just like nurses do, just like physicians do. So yeah, I hope that answers your question.
I have a follow-up. So when you take such as you, when you took your first exam, how, and the laws changed throughout the years, how are the pharmacists kept up with the changes in the law?
Yeah, and I think you'll probably hear for some people later. That's incumbent on the pharmacist. I mean, that is incumbent on the pharmacist to know the laws and rules. But our associations in the state, the New Hampshire Pharmacists Association, will often do an annual law review, and which I'm going to point out a little something, which is interesting. Oftentimes, the exam questions are written 2 years ahead of time. So there's been cases where the question is asking you one thing, but the legislature or the Board of Pharmacy may have changed the law, and you may get a question on that exam that the right answer for the exam is the wrong answer for the practice. So to answer your question, there are workshops, there are professional opportunities to get that. There's a law update, things like that.
Thank you. Any questions from the committee? See none. Thank you.
All right, thank you. Yeah.
Can you call the department? I would send her e-bars, but they're way down here.
Yes, yeah, thank you. All right. The chair calls DHHS, Trish Tilley and David Chorney.
Good morning. Good morning, Chair. Good morning, members of the committee. My name is Patricia Tilley. I'm an Associate Commissioner with the Department of Health and Human Services, and it is my pleasure this morning to come and speak in support, the department's support of Senate Bill 504. Importantly, the department highlighted this strategy as part of our rural health transformation application in alignment with CMS, the Centers for Medicare and Medicaid, priorities to improve access to care in every corner of the state. My colleague Dave Chorney, who is from the newly established Office of Go North, will speak to some of the specific ways that this legislation also aligns with our rural health transformation funding. He's the money guy. I'm the public health person. You have lots of pharmacists in the room today to testify about their critical role on healthcare teams and the ways in which this bill specifically helps streamline access to life-saving therapies and medications. In particular, updates to the authority for dispensing non-controlled cancer medication makes sense to the department, especially in rural areas. We appreciate the clarification about rules around license availability, remote processing, and labeling supports, and all of that infrastructure to help pharmacies operate efficiently and safely in smaller communities and in areas where, and we also appreciate some of the areas where there were technical cleanups to 318. We also appreciate the changes to collaborative practice language and the training requirements. I think it provides clearer pathways for pharmacists to offer evidence-based services such as immunization, chronic disease management, and medication therapy management. These are routine, safe, and high-value services that reduce the burden on primary care providers and help patients stay connected to care where they live. We suggest adding the word voluntary around collaborative practice if there's an opportunity to do that, just to make sure that collaborative practice can continue in the best interest of the team and patient, something to consider. We believe expanding the pharmacy scope of practice is not just about shifting work from one profession to another. It really is about ensuring that every qualified member of a healthcare system and team can contribute fully. DHHS supports the effort of SB 504 because in rural New Hampshire in particular, where provider shortages are real, we think that this is going to improve safety. We think it's going to support the health of our communities. And as David's going to highlight, this policy is going to help us leverage some federal funds that are going to provide some wholesale improvements throughout rural areas of the state. So thank you for that consideration on behalf of the department. I'm going to hand it over to Dave.
Thanks, Tricia. And good morning. For the record, it's David Chorney. I'm the new Director of Financial Sustainability and Policy for the Governor's Office of New Opportunities in Rural Transformational Health. For short, we call it Go North. And so as Tricia mentioned, there's the CMS Rural Health Transformation Grant, which is a $50 billion competitive grant between states to transform how rural healthcare is delivered in rural areas. Part of that grant application, states were asked if they would commit to certain policy commitments, and those policy commitments are around healthy lifestyles, expanded scope of practice, streamlined licensure. What's important here is one of those commitments was the expanded scope of pharmaceutical practice to include independent prescribing and the ability to independently order lab tests. And the policy commitments translate into more dollars for New Hampshire. So by committing and implementing the policy, the state gets more money in its grant award. So the first budget period, which is around an 18-month time period, it was $204 million. There's 5 budget periods, so it's just over $1 billion. CMS will recalculate the award on an annual basis. So not implementing policy commitments will have an impact on future funding for the state. The big component for New Hampshire around the pharmaceutical scope of practice was reducing laws that would inhibit a pharmacist's ability to independently prescribe and independently order lab tests. And so I think that's why Tricia had mentioned a potential, just making it clear that the collaborative practice is voluntary to ensure that pharmacists can independently prescribe and order labs.
Great, thank you. I've got a couple questions. One, so if this was part of the grant that we got, the $204 million, and if I understand you right, there's a chance that if we don't hold up that part of the bargain, we could lose money in the future. Is that correct?
That's correct.
Okay.
That's correct.
And then the other thing I just wanted to clarify is oftentimes the department will come in and give opinions on things, but doesn't take a position. I just want to clarify that the Department of Health and Human Services is in support of this and is taking a position on this. Is that correct?
That is correct.
All right, thank you. Are there any other questions from the committee? Senator Birdsall.
I just have one. Thank you for taking my question. You had mentioned, where did you want the word voluntary put in?
It's around collaborative practice, and I think Dave can talk about that. I think he has the bill pulled up right
Yeah,
now.
it'd be line 15 on page 2. So just say the voluntary participation in collaborative pharmacy practice.
Page 2.
Page 2. And would that also include line 28 on page 2?
We could include it there too, just as belts and suspenders.
Thank you.
Any further questions from the committee? Thank you very much.
Thank you.
Thank you.
So I would just, we're going to start going through the list of testimony. And again, I want to remind folks, unfortunately, we have to have a 3-minute timer today. And I also need to note that we are going to recess at 10 o'clock very quickly for a committee photograph. But Sophie will let us know when we get to that point. So let's see, I've got Kathy Stratton.
Good morning, and thank you for taking my testimony.
Good morning.
For the record, my name is Kathy Stratton. I'm the CEO of the New Hampshire Medical Society. I'm here to testify in opposition of the bill as written, just clarifying that I have not seen the amendment. So if I'm addressing things that maybe that are on the amendment, I apologize. We have some concerns about the bill as written. As I said, we'd like to recognize the critical role that pharmacists play on the healthcare team, and our concerns are mainly around some of the points that you made, Senator Rochford. Concerned about clarity on the scope of practice, and concerns about the integrity of the communication between the pharmacist and the prescribing team. So I am going to focus for the most part on the sections that you mentioned, section 6 on page 2, 5 through 23. There are some new language there, and just want to kind of talk about how there's a blurring in the language between what is the practice of medicine and what is the practice of pharmacy. We're not quite clear from the language that's proposed here about the role of the collaborative pharmacy practice agreement, and I think we'd like to work with the stakeholders to clarify that, particularly item F, prescribing, ordering, administering, and interpretation of laboratory tests. From our perspective, there's a blurring of the lines between the practice of medicine and the practice of pharmacy. Just interested in clarifying that. We understand that pharmacists do not train for exams, and want to make sure that the critical role of examining and diagnosing and prescribing is integrated with this into this bill. I have some concerns about 33 through 37, the removal of credentialing and training, just from the perspective that every profession, every medical profession has the continuing education requirement, and I want to make sure that continues. It's essential. I mean, our worlds are changing exponentially, and I think the intention may not be to end the continuing education requirements, but I think that is essential. Also, in regards to credentialing, like as we're looking at changing the scope issues within the Board of Pharmacy, if it changes substantially, I think additional credentialing might be important in that regards. So in summary, I just want to say the exam, the diagnosis, the treatment that physicians do is essential, and that we want to work with the stakeholders to just tighten up some of the language on this bill.
Thank you. A couple things that you brought up, and I'm going to tell you what the intent was on line 35 through 35, 36, and 37. And maybe that intent needs to be clarified, but it actually benefits your members. Mm-hmm. So your members who are contracting with the pharmacist can say, I don't think I want to do business. I don't want you. I don't believe in your ability to do this anymore. And I wanted to give them more say in how they do those collaborative practices. So that needs to be clearer. I'll certainly take that into account. I will tell you, you highlighted the same issues that I brought up. I would ask you to reach out to Beth Sargent, who represents the pharmacist community, and work on, get together and work on this. We're going to act on it in a week from today. Okay. So I would encourage you to work some of those things out and clarify some of those questions that you have. But, any other questions from the committee? Thank you very much.
Thank you.
I got Maureen Briel. I'm a pharmacist and I still can't read your handwriting, so, man. If you want to submit the written testimony, yep, Cole will take care of it.
Oh, okay. Thank you for having me. My name is Maureen Brady. I have been a practicing pharmacist for nearly 20 years, and I'm here to support Bill 504. It is a very important bill that will allow us pharmacists to practice based on our education, training, and experience, and will empower us further to help with patient access and patient safety. I'm going to talk a little bit about my background in training, and I know we have some other pharmacists that will be speaking about their work in the collaborative practice agreements, but I will also touch upon that. I graduated from Northeastern University with my doctorate of pharmacy in 2006. After I completed my 6 years of pharmacy school, I went on to do a postgraduate year 1 pharmacy residency in a VA hospital in Erie, Pennsylvania. It was a small community-based hospital. Within the VA system, I don't know how much everyone knows about this, but pharmacists are given a scope of practice that are based on standards of care versus having to have a collaborative practice agreement. So this allows pharmacists to practice and manage chronic disease states under this scope of practice. During that year, I was able to gain an innumerable amount of experience managing diabetes, hypertension, hyperlipidemia. And in the pharmacy world, an ambulatory care pharmacist position within a VA hospital is highly coveted because they do not fall within the state regulations and they follow the federal law. Because of that experience, I was able to jump into academia after my residency year. And in academia, I can assure you that didactically and clinically, we give our students a rigorous clinical and didactic education. In terms of addressing the physical assessment and exam, pharmacists are trained on physical assessment. I actually created and taught that entire lab at Northeastern University. Fast forward to now, I currently practice at Wentworth Douglas Hospital. I was hired 8 years ago as a clinical pharmacist to service 16 different providers in an internal medicine practice. Over the last 8 years, we've grown substantially to include 4 ambulatory care pharmacists in primary care, 2 in cardiology, 1 in surgical services, 1 in anticoagulation, and we have a clinical PGY2 ambulatory care pharmacy resident. We all practice under a collaborative practice agreement that lets us monitor or that lets us manage several chronic disease states. Basically, the providers send a referral and the patients get put into our schedule just as any other medical professional, just as they would do for a nurse practitioner, a PA, or a physician. And under that, we then meet with the patient. We have further access. I can get a patient in to see me in 2 to 4 weeks, where a provider needs to have a follow-up in 3 to 6 months. So many of my providers are like, I'm sending you all of my hypertensive patients because I know it's important to get their blood pressure under control in a timely manner, and I'm not able to see the patient that frequently. So we are able to change medications, order and administer medications, order and administer medications, and develop drug therapy plans that follow patient safety, efficacy, and being cost conscious, because that is another huge part of managing patients.
Thank you. So you're doing this in an institutional setting. Do you see the value if you were to do it in a community setting? Would it improve access?
Yes. Even our endocrinologists have said that they were overburdened, and they revamped their referral to actually include that the patients need to see a clinical pharmacist prior to them accepting the referral to endocrinology, which has helped access to diabetes care and helped to reduce burnout of our endocrinologists.
So just as a follow-up to that, you're a gatekeeper, you're kind of doing the initial evaluation for the endocrinologist, and if you can take care of it, they don't need to go to the endocrinologist.
Exactly. If we can manage it, they don't need to go to the endocrinologist. And I'm the first to say, oh, this patient is too complex for me. We've been trying for this long. Please go see endo.
Thank you. Are there any other questions from the committee? No, thank you very much.
Thank you.
So I've got Bob Terrio. I have Tanya Carlton, both under NHSHP. You guys want to come together? Oh, look at that. You read my mind. Thank you.
Good morning, Chairman Rochford and members of the committee. My name's Bob Terrio,
And my name is Tanya Carlton.
and we represent one of those professional societies that you mentioned, the New Hampshire Society of Health System Pharmacists. So we strongly support the definition of the practice of pharmacy in Section 7 and the revisions to the CPA in Section 6 and Section 7. You're going to hear how highly trained pharmacists are. Tanya and I have a combined 65 years of experience in pharmacy. And, over the years, we've seen the practice of pharmacy change dramatically. And, the major change is pharmacists are now providing direct patient care services. And these direct patient care services, they're not only just collaborating with physicians and other providers. As Maureen stated, and you'll hear other testimony, they order medications, they administer medications, they monitor labs, and they help patients safely manage these chronic conditions like heart failure, diabetes, hypertension, hyperlipidemia. However, one of the things, as Chairman Rochford stated, pharmacy is one of the most highly regulated professions. And our regulations are really bright lined, which means, it's very prescriptive on what we can and cannot do. An example, too, that we've not been able to fully implement is something simple as smoking cessation. Our rules related to smoking cessation tell us that we have to have insurance, how much insurance we have, the form that we have to follow to assess the patient, the form that we have to hand out to the patient. And you'll see and you'll hear from our pharmacists that it's a PharmD doctorate program. Many pharmacists are residency, postgraduate 1 and postgraduate 2 training, and they are highly skilled pharmacists, and they're able to practice to the full extent of their license. So basically 504 modernizes, as Chairman Roches says, to a standard of care model. And this is similar to physicians, nurse practitioners, and physician's assistants who we work very, very closely with. So I also wanted to note that the change highlighting this standards of care practice model is really important because it addresses our health workforce shortages and the increasing demand for pharmacists, especially in our rural areas and our underserved areas. Pharmacists are readily available. They're the most accessible healthcare profession around. And so enabling this standards of care will enhance practice. So
All
I want
right.
to serve.
Now, was that 3 minutes, Sophie? Okay, I'm gonna give Tanya 3 minutes because you're good? All right. So I do have some questions for you, and then I'll open it up to the committee. The first question is a little different than what you testified on. Just so for the record, you and I both served on the Board of Pharmacy, and I believe you're still serving on the Board of Pharmacy now. And I'm not asking you for a position from the board, more of personal experience and, what you've learned over your time there. Talking about the jurisprudence exam, I highlighted some of the weaknesses of requiring that. Would you agree with that? And what's your opinion? And I don't know the answer to what your question.
Yeah.
It's very risky for me to ask you this question because I don't know the answer to it. So, what are your thoughts on that?
I mean, right now, my position is similar to you. I took the exam 40 plus years ago, and it's very, very different. I'm currently reviewing the rules, and we're debating eliminating the exam. Some of the guardrails that other states have put in is requiring continuing education related to rules. We've had discussions about our professional society doing annual rules revision. But yeah, my feeling is similar to yours. We're a profession, And as a profession, I feel like it's my obligation to stay current with the rules. I mean, we don't require physicians, nurse practitioners, PAs to take a jurisprudence exam. It's up to them to stay current. It's up to them to know the rules. So I'm in support of that.
Thank you very much.
Can I just add to that? I would also
Absolutely.
state NHSHP is a subsidiary of American Society of Health System Pharmacists, and they do have policy in place to state that they are in support of the removal of the MPJE across the country.
The elimination of MPA, and just for the committee, that's the multi-state jurisprudence exam, and there are other states that are eliminating. Like I said, Vermont is, I believe, would you believe that Vermont is probably the most recent one that eliminated?
I believe you are correct.
All right. Are there any questions from the committee? No, thank you very much. Let's see, I've got Christopher Lopez.
Hello, nice to see you all. I'm happy to be here. I appreciate the opportunity to talk to you guys. So my name is Christopher Lopez. I'm a clinical pharmacist. I'm an ambulatory pharmacist, which I understand a lot of people are not necessarily familiar with. I work for the Elliott Health System, and I oversee the ambulatory pharmacy program. We have pharmacists embedded in internal medicine practices, family practices, palliative care, infectious disease, and behavioral health, and geriatrics there. I personally support 3 different clinics within the Elliott. 2 of them are in Londonderry, a family practice clinic and an internal medicine clinic, and also a geriatrics clinic based out of Manchester. My day-to-day is basically patient-facing. I see patients all day long. I average about 120 to 150 patient appointments each month. 100% of them are the direct result of a referral from a physician or a nurse practitioner. I'm an integral part of the practices. A lot of the physicians and nurse practitioners rely on me. They refer patients for management of chronic conditions, diabetes, hypertension, hyperlipidemia. I'm here to support the legislation and answer any questions you guys might have, because I understand that this isn't something that a lot of people are familiar with. A lot of the patients that I meet for the first time, I have to explain. They're like, I'm seeing a pharmacist. This doesn't make sense. So if there's any logistical questions you guys have, I am happy to answer them, but I'm in support of this legislation.
Are there any questions? Thank you very much.
Use less than my 3 minutes.
Got off
Thanks,
easy,
guys.
right? We appreciate that. Let's see, I've got Amanda Morrill.
Good morning, Chairman Rochford, members of the committee. Thank you so much for hearing all of our testimony. My name is Amanda Morrill. I am president of the New Hampshire Pharmacists Association. We work very closely with the New Hampshire Society of Health System Pharmacists, who you've already heard from today. I've been a pharmacist and pharmacy educator for 15 years, and I'm also a board certified pharmacotherapy specialist and a certified tobacco treatment specialist. And I'm here on behalf of myself and NHPA to urge you to support Senate Bill 504. I just wanted to take a couple minutes. I have some handouts for you, and have some written testimony I'm going to email for you, but I just wanted to take a couple minutes to clarify some things and bring up some of our points. So with this legislation, pharmacists are going to be able to provide care to Granite Staters consistent with their education, training, and experience. This supports evidence-based patient care and is in line with the governance of other health professions in New Hampshire as well as in other jurisdictions. I did hear a question earlier about getting rid of the education part. Oh my gosh, what line was it? Or the continuing education part. That was just related to the collaborative practice agreements. With this bill, pharmacists would still be required to do their annual continuing education hours. It's 15 per year. I also wanted to clarify that pharmacists take 2 licensure exams currently in order to be licensed. One of them is the NAPLEX, so it's the North American Pharmacy Licensure Examination. And that one does cover our clinical expertise, our pharmaceutical knowledge, and it still includes federal law and laws surrounding compounding. So that would still be assessed even with the amendment to remove the jurisprudence exam. Let's see, I got all my notes here. As Senator Rochford noted, there are 37 other states that allow pharmacist prescribing in varying capacities, with Alaska, Iowa, and Idaho being the most broad currently. We do support a broader change because it does prevent administrative burden as healthcare and technology changes. We wouldn't have to come back here and be like, and add this, and add this, and add this, so on and so forth. I did also hear questions about the definition of scope of practice. NHPA is so willing to work with the medical society, other stakeholders, because we actually do have a recommended definition for scope of practice, and it is based on what the PAs have. Because again, we're just trying to regulate our profession in line with the governance of other professions in the state. My very last thing is pharmacists are educated on evidence-based clinical decision-making, therapeutic treatment planning, which includes diagnosis and prescribing, and medication therapy management strategy development. And that line I just read to you is directly from the 2025 standards for accreditations of Doctor of Pharmacy programs. So with that, I do encourage you to support this bill, and I'm happy to answer any questions you may have. Ooh,
Perfect timing.
Thank you.
I should give you another minute just for that. I do have a quick question for you, and this really gets around education.
Yes.
You know, I'm ancient, and and I had an excellent education, and I feel like you know, I really, actually, quite frankly, was even with my education at a bachelor's level degree, was prepared even to do some of these things.
Absolutely.
What level of education are we graduate? We have a school of pharmacy in the state of New Hampshire.
Mhm.
And I think Dr. Lopez mentioned the fact that some residency and just what is this? What is the average student doing? I mean, I think that residencies are becoming standard, but if you could just expound on that a little bit, what the level of education that these professionals are achieving.
Sure. So in order to be a pharmacist, even though many of us go by our first names, I'm sure you've been to your local pharmacy and everyone's name tag says their first name, you have to earn a Doctor of Pharmacy degree. So it is a doctoral degree. In addition to, after achieving prerequisites or a bachelor's degree, is 4 years of graduate education. The pharmacists, they get 4 years of graduate education that includes 1,740 hours of clinical experience. So we actually have some PharmD students in the room right now who are on their clinical rotations, meaning that they're spending six-week rotations with pharmacists who practice in a variety of areas. And that is their second bout of clinical experience as part of the PharmD program, which is standard. Many pharmacists also choose to do a postgraduate year one residency, meaning it's another year of clinical training, but this time they are actually a licensed pharmacist. When I graduated, which was not that long ago, but it was 2011, so it was a little bit ago, there were very few residencies in New Hampshire. It was pretty much Dartmouth and Eliot. And now, as you've heard today, there's many, many more options. We also have second-year specialty residencies. So pharmacists are achieving a lot of training. You may have also heard me say at the beginning that I'm a board-certified pharmacotherapy specialist. So pharmacists who achieve that training can also take an additional board exam that has an additional 120 hours of CE credits over 7 years to maintain to be further specialized. So we are a very highly trained profession. It is a doctoral degree. And even though we go by our first names because we're the most accessible healthcare providers. And unfortunately, over 40 Rite Aids closed in the past year. With the changes at Walgreens from being public to private, many of those have closed. So we've seen a decreased access to care for the patients of the state of New Hampshire. And we're hoping that changes like this can improve the health of all Granite Staters.
Thank you. And it sounds to me, I don't know if you would agree, but would you agree that perhaps in the state of New Hampshire, our rules and laws have not kept up to the level of education and training that our pharmacists are getting?
Absolutely. These laws have been changed throughout the years, but they have not been changed at the pace or to the depth at which the education of pharmacy has been evolving.
Great, thank you. Are there any other questions from the committee? Thank you very much.
Awesome.
Seeing
Thank you
that,
so
I don't
much.
have anyone else signed up to speak. Is there anyone else who'd like to speak on Senate Bill 504? That, I'm going to close the hearing. The question is, if we want to execute, no, the medical society did bring up some questions. I'm going to give them a week to talk to the pharmacists and see if they can't answer some of those questions. So there's your charge, pharmacists and physicians, to come back in a week.
And 10:15. We'll
Oh, yeah.
take a break. We can let everybody-
Yep, I will. So,
Senate practice?
Wow. You know how to empty a room.
so Senator Abar is going to open the next hearing because I'm introducing the bill, but I just need to make an announcement that at 10:15, we're going to recess the hearing regardless of where we are or who's speaking, because the committee needs to take a quick photo.
I might.
I'd be happy to. I'll impress your kids for you. And with that, we're going to open up the hearing to SB.
Thank you very much.
617 here from the prime sponsor.
For the record, my name is David Rochefort, Senate District 1. Before this is we've gone round and round on this bill that you have before us. And, it focuses around prescription drug pricing. And we've all been to the pharmacy and we've seen the advertisements for these prescription discounts, prescription coupons. But there are a new class of prescription discount cards that are out there. One thing that people don't realize is when they use one of those cards, and many times that your personal information is captured at the pharmacy, it's transmitted up to a third party, and that third party sells and transmits all of your information out to anybody that wants to buy it. There are new discount programs that are out there that in many cases actually offer a bigger discount, lower the price even more, and they don't sell your data. And the snag that we ran into is, and I think you're going to hear specifics probably after me about our particular one that actually the state of Vermont just implemented about 3 weeks ago, but it requires it to be a state-sponsored program. And that's where we've run into a lot of questions over the last several months, because when we authorize the state to enter into one of these agreements, it has to land in a department. And I've talked to DHHS about it, and they said, "Well, we're more Medicaid. We're not consumer discount cards." I talked to Mr. Arlinghouse over his department. He said, "Well, we deal more with the state plan as far as employees." So you're going to hear from the Department of Insurance. They drew the short straw, and they're going to tell you that they probably aren't the most appropriate place for it as well. But for the purpose of this discussion and this bill, whether they want it or not, they got the honors of this. So we're going to hear from the department, I hope. I didn't look at the sign-up sheet to talk about that a little bit. But ultimately, I think the goal coming out of the committee is wherever we decide the best place is, I think it's really important that we adopt these types of discount plans and discounts. It's pro-consumer, it's pro-state, it's pro-consumer in price, it's pro-consumer in privacy. We, of course, know that we put a high value of privacy in New Hampshire, but I think we're going to have people speak after me that can probably give a little more depth on that. I know I'm waiting to hear from the department, and like I said, I know what they're going to say, but we'll hopefully work through this in the next week or so to most appropriately place this bill.
Questions from the committee? Seeing none, thank you, Senator.
Thank you.
Michelle, if you'd like to come on up, seeing how. The iron is hot.
Good morning, everyone. Michelle Heaton. I am the Director of Life and Health at the New Hampshire Insurance Department. I think as currently drafted, we have concerns about it because it's basically saying that we can't enter into a cooperative procurement group via an intergovernmental agreement. So usually that would be like an MOU with other agencies or other government entities. Based on that just broad statement, we don't know what we're being directed to do. Like, what do you want us to do? It sounded like, I think we misinterpreted what it was trying to do. We thought it was maybe going as a different aspect of maybe the Prescription Drug Affordability Board, where it'd be more of a purchasing group to purchase drugs for some types of programs like the state plan or 5B risk groups or something like that. That's well outside of our jurisdiction. We don't actually assist in buying anything. And so that would be, not the appropriate place for it. But I think what you're actually describing, Senator Rochefort, is a little bit different. And so at the department, we do regulate discount medical plans. Now, some of these prescription drug programs do not fall within that statutory definition of a discount medical plan, but I think there are opportunities for us to regulate what you're talking about, those types of discount programs to put in certain consumer protections. So I think, I'm not sure that this language is workable as drafted, but I think having a little bit of a better understanding of what you're aiming to do, I think, that would be appropriate for the insurance department to do. And so we're happy to work with you to figure out how to go about doing that. And maybe it could be tweaking some of the statutes we already have, or maybe we do need a new chapter. My only hesitation is I think a week is a bit ambitious to do all of that, but we're happy to work with you to get something for later in the year. I'm happy to take any questions.
Thank you very much. I know you've been very busy this year, and a lot of it is because of me. But I appreciate the time. But what I'm going to do, Sam Burgess is going to be talking next, and he has a lot of the details. And I'm going to task him with reaching out to you, and maybe we can get something. If not, to come out next week, then maybe a floor amendment in a little bit longer. But that's he'll be tasked with that next. So Sam, get ready. But thank you. Are there any other questions from the committee? Thank you very much. Sam Burgess.
Thank you, Senator Rochefort. Thank you for hearing my testimony today. My name is Sam Burgess. I'm the Healthcare Policy Director at New Futures, and we are here today in strong support of
Sam, you pull that.
Apologies. We're here today in strong support of SB 647. I'm joined by my colleague, Stephanie Krieg. She is here with the state of Connecticut, who has already adopted the ArrayRx program to great success. So I think maybe the best way to go about this is Stephanie is our resident expert on the program, its functions, sort of how this looks in practice. So I'm going to defer to her to go first, and I'm going to throw in some comments as well after, if that's okay.
All right. Thank you, Stephanie. You're up.
Great. Well, thank you so much for having me. Stephanie Craig. I'm the Senior Advisor for Health Policy Initiatives at the Connecticut Office of the State Comptroller. I'm a public health professional.
And I'm going to ask you to pull that a little closer
Sure.
too.
No problem. I'm a public health professional, and I am also someone who manages our state employee health plan, specifically with pharmaceutical benefits. So, we hear it all the time. People go to consumers go to the pharmacy counter. They can't afford their medications. It's usually they're higher than expected. There's a variety of different reasons for that. Sometimes the insurance doesn't cover it. Sometimes they don't have insurance. Sometimes they haven't met their deductible. There's a variety of different reasons. In these moments, people are really left trying to figure out what it is that they're going to do to be able to afford that medication. And that's where ArrayRx comes in. We've provided that solution. So ArrayRx, in the simplest of terms, is a multi-state collaborative. We've worked on pharmacy solutions that help improve medication access and affordability. One of those tools is the prescription drug discount card program that we're going to be talking about today. Anyone living or working in a participating state in ArrayRx is eligible for this program, regardless of age, income, insurance, or immigration status. You can enroll for free, and you can receive a card that provides discounts on medications that you use every day. Consumers can look up the prices ahead of time They can also compare costs at pharmacies in their area to determine what the best possible price is for them. And the program provides savings both in front of and behind the pharmacy counter. So anything with a national drug code or NDC level code is eligible for some sort of discount. That includes things like prescriptions and diabetes testing supplies and everything in between. This also operates completely outside of the insurance system. So when someone uses a card, the prescription is not run through their insurance. The insurer is not billed. Instead, the person simply pays the ArrareX price at the counter, much like they would pay for a cash price. That structure is important because it means that it does not interfere with insurance plans or premiums. It simply gives people another option to be able to use this when the price is simply too high or they don't have insurance. The program is also designed to work transparently for pharmacies. So pharmacists see the reimbursement amount in real time before completing the transaction, and that amount is final at the point of sale. The price that the consumer pays includes a small administrative fee that supports the operation of the program, paid for by the consumer, and it's built directly into the transaction price and is not taken out of the pharmacy's reimbursement.
Thank you. Are there any questions? Senator Birdsell.
Thank you, and thank you for taking my question. So if Connecticut went ahead and, how did they market this or get the word out to the citizens? Because I think that's probably kind of it sounds like a good program, but I want to make sure that our elderly and those that can't afford it get the word out. How did you market it out?
Yeah, that's a really great question. So I'm actually the director of the program for the state. And one of the big things that we did is we really got together our stakeholders, the people on the ground that are doing this work, that are doing more broad social determinants of health work. Because ultimately, when someone is experiencing cost issues in other areas, they're also experiencing this in the medical system as well too. If you can't afford food, if you can't afford housing, you most likely also can't afford your medication. So we really worked with folks to understand where in the process during any screening where they're looking for outside support, where they might be struggling for those pharmacy benefits. And that's when we introduce this. We say, hey, it sounds like you're struggling to afford health insurance. It sounds like you're struggling to afford your health care in general. This is a free program that you can use to support. We also connected with our sister agencies. So our state's ACA, Access Health Connecticut, we actually work in collaboration with them all the time. So when people are signing up for those programs and some of those high deductible health plans just are outside of their reach for medications, we also highlight that there are programs in the state of Connecticut that can help, and ArrareX is one of them. So we find that to be also really helpful. And finally, we connect with every single one of our 169 states, cities and towns with their senior agents, with their social services departments, and with their local health departments to talk about these benefits. And we offer all of the resources, education, and training at no cost to any of them. So we have a pretty robust system. And so far, we have over 26,000 folks who have been registered in the program, and they're seeing an average savings of over $200 on their medications. In general, since signing up, we have seen collective savings of over $2 million.
Senator Abar, his
Thank
question.
you. Thank you for taking my question. So you said that the pharmacists see in real time the discounts?
So
As opposed to what?
So they're seeing the real-time cost to both the consumer as well as what they're actually going to be reimbursed for. So the trouble with a lot of the for-profit discount cards right now is that there is a fee for the pharmacist to even be able to see what that discounted medication will be. So not only do they have to pay as a pharmacist just to be able to see what that cost is going to be, but there are sometimes retroactive fees or clawbacks based on opaque systems that essentially wind up costing the pharmacy more money than it would actually be worth to dispense the medication at that price. With ArrareX, we don't do that. There's no fees associated with the pharmacy being able to see anything. They can see exactly how much within their network agreement with the broad network, exactly how much they are going to be paid and exactly how much the consumer is going to pay for the medication.
Okay, I'm going to try to decipher that, but so pharmacists have to pay for this information, but this program, they don't. correct?
Yes.
How is this funded?
This is funded by a small administration fee that is paid by the consumer at the point of sale. It's built into the discounted price. So that fee helps maintain the broad network. It helps us ensure that they can process the claims in real time, those types of things. This is a not-for-profit card. So you're really, that small administration fee is just to maintain the program itself.
One final question. This will be my last question. So how does the insurance department get involved or not get involved with this?
So for the state of Connecticut, our Department of Insurance is not involved. This is housed in our participating program is housed at the Connecticut Office of the State Comptroller. We manage our state employee health plan. And so because we do this work and we do a lot of health policy to support access and affordability across the state, we felt like it was a really great complement to be able to put here. As someone who manages the pharmacy benefits for state employees, I understand what those pharmacy benefits look like and really where we need to provide more oversight and support. And so it was a natural complement to be able to keep it in our office.
Any other questions? Senator Long.
Thank you, Mr. Chairman. Thank you. Now, setting up this program, were there a lot of, once it was initially set up, was there a lot of changes that had to happen, or is it pretty much the same program that was initially set up?
It's the same program operationally that was initially set up from day one. What really makes or breaks a successful program is being able to develop the strategy and the relationships with the stakeholders and making sure that you have someone at the table who understands what their issues are and are able to support them with the tools and resources that they need to be successful. Stephanie from the Office of the State Comptroller is not going to be the person to change hearts and minds of every single resident of our state. However, the folks that they see every single day, their senior agents, their social services directors, those people need those tools and resources because they're trusted messengers. And those are the folks that are going to help. And it's my job to make sure that they have what they need.
Great, thank you.
Thank you very much. And I think, we've talked, Sam and I, several times about this, and I know what the end point I want to be. I think one of the struggles we've had, and we've heard it from the previous testimony, is you look at Connecticut, what they are doing is we don't necessarily do things the way they do in Connecticut or Oregon or Washington. So the big struggle is how do we get to the end point? And I think that's, and I highlighted that when I introduced the bill. I picked DOI because they drew the short straw. Sorry. Publicly apologizing to you, but as a placeholder. And I don't know, Sam, if you can connect with them and maybe walk through that in the next in a short period of time we have, and see that what we need to do to get there. I think we all see. I mean, I do anyway. I see the value in it, and these discount cards and discount programs are being used, but in order to get to the better type, there's something the state has to do. And I know what the language is. We have the language there, but where do we put it? How do we do it? And I was, I think that if we hadn't had such a busy session this year, we'd have been able to spend a little more time on it. But I do want to see something if we can do that. So I would ask you to connect with them and circle back with me.
Certainly, yeah. Thank you, Senator. And I have a couple quick comments in response to what we've heard here. I think Senator Birdsell's question is good in respect to promotion of the card. I think two things. I think one thing we haven't raised is that this card does, in fact, bring in a new source of revenue for the state of New Hampshire. DHHS, through a previous study through the PDAB, estimated that could bring in a few $100,000 in the state of New Hampshire in a matter of years. So I think that could be self-affecting when it comes to the promotion and maintenance of this program. In the meantime, I certainly think that nonprofits and in the space could do outreach and promotion of this card to really get the word out about that. So I don't think it's going to be an issue. I just want to go over again. I think that this program has some really unique benefits that are going to be great for the state. It's no cost to the state, revenue generation for the state, which is a rare combination, to not have to pay upfront, but to still reap the benefits of the program while providing privacy protections to your constituents. There's immediate savings at the pharmacy counter. I believe at all the states that are as part of this program have seen savings up to 80% on prescriptions at pharmacies, especially on generics. I think through the DHHS report, they already did an analysis and found that Almost every single pharmacy in the state is already a member of this program. So it's statewide pharmacy access from the jump.
Hey, Sam, I am going to stop you right
Yes.
there. I know you've had your 3 minutes, so we're going to, and then we have to recess here at 10:15.
Certainly.
So, but I would ask you to connect and see if we can't get something here. I am going to recess the committee. We'll be back in 10 minutes at the most, so don't go too far. We still have one other speaker signed up on this bill. So, thank you. All right, we're going to come out of recess, and the chair calls Ann LaForce. Perfect. Just let me know who they are, and we'll check them off the list.
Good morning, I'm Ann LaForce.
And I'm Mary Roberge. Dan Wise was supposed to be testifying with me, but he had to leave because he had a prior engagement.
All right, thank you.
Thank you, honorable members of the committee, for this opportunity to testify today. My name is Ann LaForce. I'm a retired nurse and a proud AARP volunteer member. I'm here to testify on behalf of myself and AARP NH in support of SB 647. After decades of caring for patients across our state, I've seen firsthand how critical affordable prescription drugs are to keeping people healthy and independent. Unfortunately, too many New Hampshire residents still struggle to afford medications today, and so many people I've seen have to delay filling prescriptions, or they try to stretch their medications because of cost, and the data reflect this. More than half of Granite Staters worry about affording their prescriptions, and 1 in 4 had to either cut doses, skip doses, cut in half, or leave needed prescriptions at the counter. And as a nurse, we know that these are not only heartbreaking, they're dangerous consequences. No one should have to choose between affording medication or paying for groceries, rent, or utilities. So that's why I'm here in strong support of SB 647, which would allow New Hampshire to create a free prescription drug discount card program. It could provide significant savings on commonly used medications, would be available to all residents, regardless of age or income. And as you heard earlier, just as importantly, it protects consumers by ensuring no personal data is sold. It's a common practical step forward. So I respectfully urge you to support this. Thank you.
And as I mentioned before, my name is Mary Roberge. I live in Manchester, New Hampshire. Also, in addition to being a volunteer for AARP, I do want to let you know that I do work part-time for a social service agency. And one of my tasks is to make sure that our clients have adequate insurance coverage for their health and prescription coverage. I'm not going to repeat what Ann did say, but I do want to tell you from a personal perspective that as my mother's caregiver, she faced the same exact situation. She had one of many medications, but this one medication, the cost of it was half of her Social Security benefit. You can imagine how difficult it is for an elderly person in their 80s trying to pay their rent and get groceries and just have a good quality of life. For this reason, and because I also see a lot of my clients that are faced with the same situation, I firmly believe that we should have this prescription drug discount program. And I just want to emphasize again what Ann had to say about the fact that it is a cost-saving measure. And we've heard from another company of what the cost savings have been. So thank you very much for listening to me, and I will entertain any questions that you may have.
Great, thank you. Are there any questions from the committee? No, thank you very much.
Thank you. I'm sorry. I do have testimony, but I will be emailing that to you electronically. Thank you.
Mike, I have you signed up, but I don't have you signed up to speak. Did you want to speak? Okay. Is there anyone else that would like to speak on Senate Bill 647? With that, I'll close the hearing. going to open the hearing on Senate Bill 607 relative to short-term limited duration health insurance policies. With that, I think Grant is here to introduce the bill.
Thank you, Senator Rochford, members of the committee. My name is Grant Bossy. I am the Deputy Chief of Staff of the New Hampshire Senate, here to introduce Senate Bill 607 on behalf of Senator Dan Innes, the bill's prime sponsor. Roughly 64,000 people in New Hampshire went without health insurance in 2024, and that number is likely to increase this year due to significant individual and group premium increases for 2026. People need affordable options, including short-term plans. Under current regulations, which have not been updated since 1995, short-term plans are limited to terms of up to 6 months, and renewals are prohibited. This initial duration limit and prohibition against renewal unnecessarily limits the utility of short-term plans to consumers, disrupts continuity of care, and is out of step with the modern regulatory environment for health insurance. I'm here to introduce also on the Senator's behalf Amendment 260890S for the committee's consideration. This amendment would make updates to short-term health plan duration and renewal limits to reflect the modern insurance regulatory environment and ensure these plans can fill coverage gaps until the next coverage year or until personal circumstances improve. Under the amendment, someone could purchase a short-term plan for an initial period of up to 12 months, limited renewability for no more than a total of 24 months. Similar initial duration and renewal limits are in place in 29 states. Short-term plans are an important safety net for people who are just starting out at work, between jobs, wanting to start their own business, or who are priced out of comprehensive coverage. Generally, these plans offer much lower premiums in exchange for more limited coverage and higher deductibles, while ensuring that someone does not bear the full brunt of a major medical bill without any type of coverage. Short-term plans are not a fit for everyone, and the amendment would increase transparency with disclosure language that highlights the potential limits and trade-offs of these plans. Comprehensive coverage remains available to those who want and need it through the individual or group markets. Thank you for your consideration of this bill and this amendment. If you have any questions for Senator Innes, I'd be happy to get you an answer.
Thank you very much. Are there any questions to give to Senator Innes? No, thank you very much.
Yep.
Chair calls Nancy Vaughn.
Good morning. For the record, I am Nancy Vaughn, Government Relations Director for the American Heart Association, and I am here today just to provide comment on the perspective that the American Heart Association has on short-term limited duration health plans. And I believe I'm listened into the amendment that is being offered out there. So I would be happy to work with the committee also on an amendment for this bill. And again, we are not opposed to the bill. We are not in support, though, of the way it is written currently. So currently, it really tethers the terms and duration of a short-term plan for New Hampshire to federal law. So the American Heart Association asks that the legislature set clear limits on initial terms and renewals using current federal limits on the short-term limited duration plans, which is for an initial term of 3 months with an optional 1-month renewal for a total duration of no more than 4 months in a 12-month period. And so I believe that this is a shorter term than the other amendment that is out there. So I know that you have got to put some time into thinking about this for New Hampshire. And I won't go into the rest of my testimony. You can read it if you like. It really just goes into our perspective on short-term plans and the fact that they have much more limited benefits than other plans. But we do understand that this is a gap coverage for people that's necessary. So.
Thank you very much. Are there any questions from the committee? Senator Prentice.
Thank you. Good to see you, Nancy. I think
too.
you already answered this, but and you're going to be looking at the amendment may solve the timing problem that you just brought up.
It may, yeah. But at least it is a step in the direction that we would like to see of not just making a reference to following the federal law, whatever that might be at any period of time. Yeah.
All right, good. So, yes.
Thank you. Any further questions? Seeing none, thank you very much.
Thank you.
Chair calls John Reynolds.
Thank you, Chairman Rushford and members of the committee. My name is John Reynolds. I'm the State Director for the National Federation of Independent Business in New Hampshire. We represent about 1,700 small businesses across the state. We are very supportive of the amended version or the proposed amendment to Senate Bill 607. In conversations with our members around the state last fall and winter, healthcare costs were a huge concern, which I'm sure is no surprise to this committee or any legislator. But what particularly stuck with me was talking to members in their late 40s through early 60s who said that they've gone without coverage, without health insurance coverage for years, which is a huge risk for themselves, their families, their business. Obviously, if there's a major medical event and they have no coverage, you could be stuck with a gigantic bill. And what they're not alone, as you heard in the introduction. There's 64,000 people uninsured. That's very likely that uninsured number is likely to increase for the reasons mentioned. That's what's happening in other states this year, which are also experiencing large premium increases in the individual market and group markets. What our members are looking for is a bridge. And unfortunately, the current state regulations or state limits on short-term plans don't allow these plans to really be a true bridge. They were adopted in 1995, long before the limited open enrollment period under the ACA. So for instance, if you don't buy coverage during open enrollment or you have to drop it early in the year, say you buy a short-term plan in March, that'll get you to September. There's no renewal. You can't renew it, so you have to start all over with a new plan, which is frustrating, unnecessarily burdensome, and potentially disruptive to continuity of care. And it's also it also eliminates the ability of people to use them as a bridge plan until their personal financial circumstances allow, or maybe there's over the rainbow somewhere there's healthcare reform that really delivers a low-cost system, high-quality, low-cost system. And then lastly, the amendment increases the transparency by requiring a disclosure requirement. They're requiring a disclosure statement that discusses the key differences between short-term plans and comprehensive coverage. There is a required disclosure in federal law, but this ensures that regardless of what happens to future federal rules, that would remain in place at the state level. Appreciate the New Hampshire Insurance Department working with us on that language. And then just the last few things. Short-term plans are still required to cover state mandated benefits. So, sorry, lost my place here. Apologize. Still required to cover state mandated benefits, and they can take a variety of shapes and forms as they do in other states. So it's not necessarily always strictly high deductible. There can be trade-offs between premium and deductible and out-of-pocket costs. So happy to answer any questions.
Great, thank you. Are there any questions of the committee? Thank you very much.
Thank you.
So that's all I have signed up for 607. Is there anyone else that'd like to speak on Senate Bill 607? With that, I want to close the hearing. Oh, John, you got it under the time limit. So I'm going to open the hearing on Senate Bill 456, establishing the Commission for Children's Futures, and I'll call Senator Sullivan.
Thank you, Mr. Chair, members of the committee. For the record, my name is Senator Victoria Sullivan. I represent Manchester's South End, wards 5 through 9, and the beautiful town of Litchfield. Today, I bring before you Senate Bill 456, establishing the Commission for Children's Futures. And the reason that I brought this forward is because some things were brought to my attention from some of my constituents. Things like childhood cancer, that we have some cancer clusters in the state that nobody's really discussing. We have gang violence in the state that nobody's really discussing. We have kids that are being diagnosed with mental illness at an alarming rate, and we have kids that I think if we dig into this, we'll find are being overprescribed medications. So this is a way to bring, instead of reinventing the wheel of some of the data that we already have, to bring that data together into one place where we can look at it with other stakeholders and try to see where the trends are, try to see where we need to help kids more, really get a realistic view of where our kids are at physically and mentally, and work as a state to make it a better place for our kids. And if you want to, so the first page just talks about how the commission will be set up. And then we go into the details of it. So the usage of individual education programs, IEPs in schools, and trends with IEPs over time. The longitudinal monitor changes in the types of support students are needing in the classroom. We hear all the time that kids are not getting their IEPs met, that the schools are falling short on this, and we need to figure out why. And we also need to look at, there's been an incredible increase in kids that are put on IEPs. Are we putting too many kids on here that don't actually belong there? Is there some other service that they should have instead of that? The same with 504s. Child's use of pharmaceuticals and psychoactive effects. Reports of diagnosed mental health issues in youth. As I said, we're seeing trends upward of mental health crises in our kids. And what are we doing for that? Are we disproportionately putting them on prescriptions instead of trying to find some other way to help them? The proportion of students that know of someone who has experienced a mental health crisis, which serves as a secondary measure that is less vulnerable to self-reporting biases. Changes in the prevalence of childhood cancer and long-term diseases, and changes in autism spectrum disorder. We've seen an increase in diagnosis of autism spectrum disorder and attention deficit disorder. Examine the longitudinal data for permanent and long-term health conditions that have both environmental and non-environmental contributing factors. Our boys are being diagnosed with ADD at alarming rates, far more than girls. Is it just because of what are their expectations when they get into school? We're expecting them to sit too long. We're expecting things of them that their young bodies really can't do. And so we're saying that there's something wrong with them. These are conversations that we need to be having. The amount of mental health services provided to minors and associated trends with such services. So can we get a proper census of what services are currently being provided and have been provided to assess what has and has not been successful? I sit on the Oversight Commission of Children's Services, and we often hear about parents that cannot get mental health treatment for their children, or if they go, they're not being served appropriately. So we need to really dig into this, because we're talking about generational things here in our state. If we don't help our kids and have healthy kids, it goes to the next generation. The prevalence of criminal street gangs, as defined in RSA 651-6 in New Hampshire, and the number of incidents of violence in public schools and the impact of such incidents have on students. We have a gang problem, especially in Manchester, that nobody will even discuss. If you bring it up, people try to shut you down. We're not supposed to talk about this. And they're going into our schools to get more kids involved in these gangs. Manchester had over 1,100 incidents of violence in our schools last year. I don't know how anyone can see that number and not come to a screeching halt with everything that we're doing to examine what's happening in these buildings and why why there's so much violence there. My kids still have friends that are in these schools, and even with the phone ban, I see what's happening in there. And I pulled my kids out of Manchester schools for a reason, but there are kids that need these public schools, and we need to make sure it's a safe place for them to go. And we hear the data, and nothing happens. And Senator Long, I mean, this is our city, right? And we hear this data of 1,100 incidents of violence, and it's said like in passing. We have to dig into this and figure out what we can do to help these kids. Truancy and attendance rates in public schools. Examine trends and what types of students may be falling between the cracks and the possible predictors of mental health related truancy. The prevalence of adverse childhood experiences and the fact such experiences have on children. To not confound external factors like abuse with more generalized cases of youth mental health struggles, and with the opioid epidemic, which again is something that people rarely talk about these days. This is impacting our children at alarming rates. We have so many kids that are living in foster care or in kinship care because their parents are still struggling with addiction, or they've lost their parents to it. Childhood exposure to pornographic content is again something that we don't discuss, and how the average age of exposure has been decreasing by over 2 years since 2008, and how it's impacted our young girls and boys. Kids as young as 11 are getting their eyes on online pornography, and it's impacting the way that they have healthy relationships down the road. Youth homeless rates.
to examine how mental health crisis can both contribute to and be caused by youth homelessness. The goal in studying all this together is so that we can overlay different data sets and glean meaning from where the data moves in tandem, as well as where certain data changes are contrary to surrounding trends. For example, if we're seeing the amount of antidepressants prescribed increases at a faster rate than diagnosis, we may want to ask some questions about overprescription and how that may be affecting our youth. Also, by bringing multiple data sets together, we can parse to what extent increases in youth mental health struggles is from increased detection and diagnosis versus changes in their environment or greater prevalence of psychological disorders within the population. There may be overdiagnosis or overprescription. Things may have tangibly changed about the world our kids are growing up in that's caused this epidemic, or we could be seeing a wave of neurophysiological changes that manifest in mental health and chronic illness. By looking at all of these in concert, we have the best chance of finding the optimal path forward toward long-term positive change for the health and especially the mental health and well-being of our kids. I'm happy to take any questions.
Thank you, Senator. I do have a question. So I understand the goal is to get data, evaluate data, and see, trending and points that we may be able to go. Looking at the composition of the commission, and this is, this is not an adversarial question. It's just one for constructivism here. Do you need some membership from departments to get the data that you're asking for? And I don't know the answer to this question. I mean, so some of the stuff you're talking about would be information that I would think would be housed at DHHS or Department of Insurance, the Department of Education. The composition has people that practice in those fields, but maybe not from the department. And I'm worried that maybe you wouldn't have access to the data that you need. So I don't know if there's something you need to get that information.
Thank you for the question. On the Oversight Commission for Children's Services, we do have departments that come to us. We invite them in to bring their data in, and that's how I would foresee that.
Okay.
They just come in, they present.
So you're comfortable you have enough authority within this to get what you need?
Yeah, I
Okay.
believe so.
Yep.
And again, it's some of this data is, we're gonna have to find it. No one talks about the gang violence. I mean, I don't think in Manchester, no one's talked about it since Chief Willard, and that was 4 police chiefs ago. But some of this data we have. It's just that we haven't brought it together to look at trends. Like, we collect a lot of data in the state. What do we do with it? This is going to be able to let us bring it together, dig down, and find out if we're actually doing what's best for the kids or if we need to have a different path.
I just want to make sure you were comfortable that you would have access to what you needed here.
Yes, sir.
All right. Any other questions from the committee? Senator Long.
Yeah, just confirmation on what Senator Rochford had mentioned, getting the data. You feel confident that, let's say Manchester School District has the highest number for any of this. You feel confident that you'd be able to get that data from the school district without having them sit on the commission?
Thank you, Senator. So as far as the school violence goes, that has to be already, every district has to report that to the state. So that is on the website already for the Department of Education. You can get the gang violence stuff. You'd be able to reach out to the police department. Again, we've got members of the police force that come in for the Oversight Commission. You can have them come in and talk about what that looks like. I'm sure that they would love some help in assisting, with the gang problems that we do have with our youth in the city. So yeah, we would be able to invite different people to come in and bring their data and have the conversations with us on that commission.
Great, thank you.
Thank you.
Any other questions? Thank you very much.
Thank you.
Chair calls Jenny O'Higgins and Abby Rogers.
Good morning. Thank
Morning.
you, Chair and members of the committee. For the record, I'm Jenny O'Higgins. I'm the Legislative Liaison for Behavioral Health at DHHS.
Hi, I'm Abby Rogers. I'm the Legislative Liaison for Public Health at DHHS.
And we are here to provide some information on existing commissions and advisory bodies that currently address any issues related to children's health and safety. As you all know, and I've heard from Abby and I many times, we share Senator Sullivan's goals and passion for children's health and safety. And we just really want to make sure that you all are aware of existing commissions where this work might be able to be collaborative.
So there, today is the Oversight Commission on Children's Services, which is established legislatively within the Office of the Child Advocate, and that serves as a multi-stakeholder oversight body that's focused on the coordination and improvement of children's services across state agencies. Its membership does include legislative, judicial, and executive branches, and law enforcement and advocacy groups and folks with lived experience. And some of their key responsibilities include reviewing and promoting accountability across child-serving systems and evaluating programs and promoting best practices. And so that is a structure that's designed to bring many perspectives together statewide and look at children's services. Additionally, there is the Children's System of Care Advisory Commission, which aims to improve the outcomes for children and families, again, through a multi-sector membership of youth-serving organizations and public and private child-serving organizations, education sector representatives, and experts from community. And they are, key focus areas are on advising DHHS and Department of Education on the system of care implementation. There's
Great.
another.
Yes, thank you. From the public health side, this bill does include looking at childhood cancer. And we work with a variety of commissions that are in existence already, mostly house-based commissions on environmental health. We present to those commissions, provide data on childhood cancer prevalence, which is obviously a big importance to the state. Also, cancer information around pediatric cancer. We work with our partners and advocates to have the most update data. A lot of that is reviewed to the State Health Assessment, State Health Improvement Plan Advisory Council, which is a pre-existing commission, also under SB 85, which is a commission on environmentally triggered chronic illness, and the 737 Commission, which looks at PFAS and public health impacts. Those are both all commissions which have been in existence for at least 4 or 5 years. So that cancer work, we partner with them, we provide information, so those we're there on that. But happy to provide also information related to pediatric cancer, which is very important to any new commissions, but just wanted to let you know that that's the ones that we generally work with on this issue.
So these are existing and active commissions and advisory councils, and they do currently have the statutory ability to form subcommittees to address any emerging issues or additional subject areas. So that might be one way for us to make sure that we're collaborative, but not duplicating how we bring together these multi-sector organization commissions to do this work. And then, as you already mentioned, Senator, the bill SB 456 as written doesn't designate any state agencies as members of the proposed commission. And so we just want to make sure that you all know, we hope that you already do, that DHHS stands ready to collaborate, to provide data or any expertise as you move forward with this work. Happy to take any questions.
Are there any questions from the committee? Just had a quick comment and maybe a question here. So I think listening to the senator's testimony, I think the desire is and it sounds like there's a lot of people working on a variety of things, but maybe nobody's talking to each other. And I think the goal for the commission here is to maybe pull resources or pull expertise from all those things. And with the specific, like the state and health improvement might do something, the oversight of child services may do something else, but it sounds like she's wanting to get a little more in depth, specifically to children and these, is that, so I guess, I think I know what the goal is, and it sounds like she's got a plan for that, but maybe these other commissions touch the subject but aren't fully immersed in the subject.
I think we just want to make sure that we're not duplicating efforts and that we
Right.
collaborate well. And we have a great relationship with Senator Sullivan, so we're happy to work with her offline. We only just touched base with her in the hallway on this one, so we just probably need a little more time together.
Okay, all right, thank you. Any other questions? Anyone else that would like to speak on Senate Bill 456? I want to close the hearing. With that, I'm gonna open the hearing on Senate Bill 520 relative to breast surgeries for minors, and I'll call Senator Reardon to introduce her bill.
Good morning, Chairman and members of the Health and Human Services Committee. My name is Tara Reardon. I'm the senator from District 15, Concord, Bow, and Hopkinton, and I'm here to introduce Senate Bill 520. 520 is relative to breast surgeries for minors, and much to the dismay of Michael Graham from the Journal, this isn't about any transitioning or dystopia or anything like that. This is a response that I got from one of my constituents as soon as House Bill 712 passed last year, which limited breast surgeries at the election of a adolescent. And I'm going to read to you the email that my constituent sent to me upon passage of that bill. My name is, we'll call her Jane Doe, and she grew up in New Hampshire, and it's either Concord, Bow, or Hopkinton, because that's my district. Now, having retired from the Air Force and a second career in the defense industry, I live back here in this district again. In 1986, when I was a senior in high school, my bra size was 34EE or 34G. I play in a golf league with this woman now. She is not a big structured woman. I was never able to find bras that fit and just had to accept the closest I could get. My chest size was on my mind every morning when I tried to get dressed for school. I skipped out of dressing for gym class every chance I could get. Running was difficult, humiliating, and painful. I still have the divots in my shoulders created by the weight of my bra straps. Carloads of boys would drive by my house and scream, excuse my language, tits. I hated every second of high school because of my breasts. It wasn't until I entered the delayed enlistment program for the Air Force that my mom suggested a breast reduction surgery. I would not have been able to do the jumping jacks or the runs if I hadn't gone through the elective breast reduction in high school. Although I still regret that the doctor refused to go below a DD, that reduction was the best thing I did in my entire life. Before the surgery, I avoided running at all costs. Afterwards, I became a runner and even competed in several sprint triathlons. Before the surgery, I could not wear button-up blouses. Afterwards, I was able to wear Air Force dress blouses without tailoring. Before the surgery, I avoided any chance of being called on or singled out. Afterwards, I literally blossomed, winning awards and medals in the Air Force, graduating at the top of my language classes, selected for a commissioning program as an electrical engineer, graduating at the top of officer training school, squadron officer school, and sought after mentor for younger enlisted and commissioned women. My point is not to brag about my accomplishments. There are hundreds of women who did much better than I, but I want to show the transformation in my life that would not have been possible if I had not been able to elect a breast reduction surgery in high school. I want to emphasize that this was a routine surgery at one time in the medical world. I had several friends in college and a friend in high school who had all had this surgery. But it's really been clouded by the introduction of gender dysphoria or transitioning youth to the detriment of people who have relied on this surgery just to live a normal life. So I have had a lot of feedback since I introduced this bill and realized, and when Michael Graham wrote that in the Journal, that this was just another gender dysphoria bill, I realized that it was not clear what I was trying to do. I've passed out a couple of options for completing the sentence in 520, the sentence that currently reads, small f, at the election of the minor in consultation with her primary care physician. And my first choice of language after that is when the primary reason for the breast reduction surgery is, but isn't limited to, musculoskeletal pain, postural changes, or physical discomfort of the individual that restricts exercise and activity. And I talked through this language with my constituent back when we first talked about this. And she said her doctor wasn't willing to diagnose her as having a problem. Her problem was really her existence, her desire to be involved in athletics and to have a normal school day. So she's worried with the language that exists in the bill as written as HB 712 from last year. She would not have been able to get the surgery. Her doctor probably would have shied away from that, not wanting to be to go against the law. So I think this is a helpful solution with the added language here for the women that are in this same situation now. I'd be happy to take questions.
Thank you, Senator. And just to clarify, the two options you gave us for the amendment, you said your constituent probably would not, her doctor probably would have not chosen option one. Even if option one was available, he or she probably wouldn't have diagnosed that.
In the existing language of the law,
Okay.
HB 712, that we reviewed after it passed last year, she believes her doctor, who was an older gentleman, her
Yeah.
doctor her whole life, would probably have not wanted to cross the line and
Okay.
done the surgery.
Great, thank you. Are there any other questions for Senator Reardon? Thank you very much.
Thank you.
Chair calls Beth Scare.
Hi, I'm Beth Scare from Nashua. I'm here in opposition to SB 520, and I know Senator Reardon just said she wanted to amend the bill, but I'm speaking to it as it's written. It completely repeals HB 712, the ban on breast surgeries for minors who have gender dysphoria. And I brought stories here for you of 6 young women that had double mastectomies as teens and how they came to regret this radical surgery. Claire Abernathy says, I underwent a double mastectomy at 14 years old in pursuit of the impossible goal of changing myself into a boy. I suffer both physical and psychological pain every single day as a result. When I was a middle schooler, I could not comprehend the permanent loss of my ability to engage in a foundational feature of the class of species I belong to. I could not consent to losing a vital piece of my adult sexuality. No one has the ability to give me back what was taken from me, but you, as lawmakers, have the power to protect other vulnerable girls from my fate. I urge you to use it. Prisha Mosley said, top surgery is a form of mastectomy performed on girls and women who are tricked by doctors into believing they can become men. I had complications as a result of the double mastectomy I was prescribed to cure my mental distress. Years after the surgery, I detransitioned. My detransition led to a pregnancy, and complications arose as a result of giving birth. My milk came in, but because of the nature of my surgery, my nipples are decorative. They were removed, reshaped, and reattached in the wrong spot. I had no way to feed my baby. The pain was like none I'd ever felt before. No girl should have her breast removed because she is sad. No child should be deprived of his mother's milk because a surgeon made money from someone's pain. Layla Jane desperately needed help but found herself under the care of medical professionals who chemically and surgically mutilated her body. At age 11, Layla heard about transgenderism, did extensive research online, and self-diagnosed that she was actually a boy, and that transitioning would be the solution to all of her mental problems. Layla's doctors coerced Layla and her parents to medically transition by indicating that it's better to have a live son than a dead daughter. At just 13 years old, doctors performed a radical double mastectomy on Layla. Today, she sees the lies she was fed by medical professionals she should have been able to trust. She now recognizes the coercion she was under and seeks to shine a light on doctors in an industry that irreversibly changed her life forever. And I also have here the stories of Chloe Cole, who underwent a double mastectomy at age 15, Luca Hine, who had a double mastectomy at age 16, and Fox Varian also had one at age 16. Fox Varian won a $2 million lawsuit against her doctors. And this is plenty of information, I'm sure, for what you need to know about this bill, about how really awful it is. Thanks.
Great. Thank you. Are there any questions for the committee? Senator Prentice.
Thank you, and thank you, Beth, for taking my question. So hearing your testimony as well as hearing the sponsor's introduction and her amendment, I just want to be clear because mastectomies and breast reductions are medically different. Is it your position that a minor that, for a medical reason that is unrelated to, we have two options here, gender dysphoria or some specific, musculoskeletal, postural changes, physical discomfort, that minor should not have the ability to get a reduction to solve their medical issue, just like an adult would?
Well, the breast reduction is something that doctors are using for these girls that end up with the double mastectomies. They're calling them breast reductions. And what they end up doing is just taking almost the entire breast away and leaving very little. So I can see under her amendment, this horrible practice could continue.
Well, so just for clarity, again, reductions and mastectomies are different. I hear what you've offered in response, but is it your position that a minor that has a medical condition that is unrelated to gender dysphoria and would want a reduction, just like the case that we heard about, should not be able to have that?
Well, I mean, that 712 had an extensive list of conditions that are allowed, diagnoses that are covered. And from what I recall, it covered that issue that this her constituent was talking about, having back pain and difficulty with large breasts. That would be covered under the existing law. That would be allowed.
I want to check that 712. If you don't, I just want to see how. I think that that's what the intention was initially, but I don't think that's how it came out. Because I may have a follow-up question on that. So I'm gonna let you. Just gonna check that. For Senator Prentice.
I'm looking it up too.
So this is where there's the exceptions. Reconstruction surgeries on minors to correct malformation, malignancy, injury, or physical disease, removal of malignant, malformed, or otherwise damaged tissue, genital surgeries on minors with disorders of sex development, male circumcision, or breast surgery subject to the conditions of RSA 329.53. That's the prohibition. So we have to go, and we can look that up, Senator. We can look up RSA 329.53 too, unless you have it right there.
Looks like it's malignancy, injury, infection, malformation, reconstructive purposes, but a reduction isn't always considered reconstructive purposes. I mean, a reduction and mastectomy are just fundamentally different. So, I mean, if I may, Chair Rocha,
Yes, go ahead.
Is this a way to just provide further clarification so that the medical community and families with minors that have, again, non-related to gender dysphoria concerns can feel comfortable that they are not going to be in violation, more than comfortable, protected, that they are not going to be in violation of the law?
Are you asking me that question?
Yeah. I think that's what we're looking at.
Yeah.
Or maybe it's, yeah.
And I gotta be honest, I wasn't paying attention.
As you were looking at.
I was looking something up, yes.
I can ask, so I'll just redirect it to Beth. So this just provides an extra level of protection. It's like a belt and suspenders approach. It provides a clarification so that there won't be any question in these circumstances.
Well,
I don't think that 712 covers it, in my opinion, in the way that you have. I understand what your intent was. I was around for 712 last year. but I'm trying to understand what the harm is in putting this clarification in for those families in this situation.
I mean, I didn't catch every word of her amendment. I just want to be sure that it doesn't open up a big hole where someone who claims that they need, some poor girl claims that she needs a breast reduction when really she's looking to transition. And that would, I think, you need to be very careful with the wording because they do call them breast reductions.
Yeah, thank you, Senator. Thank you. I'm looking at 32953, and I can see the ambiguity in that, but maybe we've got some more testimony to follow, and maybe we can get to the bottom of that. So Chair calls Aubrey Friedman. Yeah.
Mr. Chairman, committee members, Aubrey Friedman, I live in Bridgewater. Originally, I opposed this bill, and for many of the reasons that Beth has said. But after listening to the senator's reason for the bill, I mean, we're talking a medical condition here. So I think this is completely okay. And it has nothing to do with the whole gender, that business. So I have also here the 32953. I looked at that. Maybe if that could be added in there or something like that. So I hadn't really, seen the amendment, but I think the purpose of what she's trying to do is actually okay. So I don't really oppose it as long as it's clear. It's physical, mental, medical condition. It's not the psychological and emotional stuff. So if it is going to cover that, only physical stuff, I would support the bill, actually, even though originally I said I'd oppose it. But after hearing that, I changed my mind.
Should I change the checkbox on your sign-in?
Yeah, with,
All right.
again, physical
Yeah.
medical interventions, not the other stuff, physical things. By the way, I did want to say something. So how come I don't see parental consent in here? That was actually something that bothered me. I'm assuming you can't get surgery without parental consent, but I didn't actually see that. And so it's got to have parental consent.
I
for the
believe it's
minors.
covered in other, it's in another section of
Oh,
law.
okay.
Yes, yep.
Okay, then I would be okay with it
All right.
then.
Any questions for Aubrey? No. Thank you very much. Is there anyone else that'd like to speak on Senate Bill 520? With that, I'm going to close the hearing. Perfect timing. I will take a motion to go in executive session so we can just talk some things. Motion and a second, Senator Avard, seconded by Senator Prentice. All those in favor say aye. Any opposed?
You want to do this one, 607?
Yeah, what is the straw poll on 607? Like, well, I'm comfortable to do that right now.
Well, hold on, we'll move backwards for a minute. Isn't this the one? Isn't this the one that the Department of Insurance wasn't sure?
No. This is the one Senator Innes's bill, 607.
Oh.
This is the one Grant introduced.
There's no opposition to this one.
Yeah,
Okay,
no opposition.
so we weren't here for this.
I'll move on to pass. Oh,
No, but-
all right, we're gonna discuss it. All right, so I'll move on to pass on 607.
Second.
We got a motion and a second. Senator Prentice.
Thank you, Chair Rochford. So in light of Nancy Vaughn's testimony from the American Heart Association, she was concerned about the timeframes. And I think the amendment as proposed would cover that. But she was talking somewhere like in 3 months, and this is in contract that is less than 12 months or after the original effective date. Just want to make sure I have that clear. So
Yeah.
12 months and up would be
Yep.
12 months and below. So someone at 3 months could have this short-term insurance.
Is less than 12 months.
I would be.
And here has no longer than 36.
So not for a full year,
So-
but less than 12 months.
Less than 12 months.
I don't
So I
have a
think,
problem.
I think we're good.
So are you moving amendment 0890S?
So, second.
Do you want to move that? You don't want to move it?
No,
All right, all right. So we've got a
Secretary
motion.
Barb moves very fast.
All right.
Yes,
He's a mind reader over there.
yes.
So all right, so that's, now we're talking about the amendment. Is there any further discussion on the amendment? So all those in favor of amendment 0890S, say aye.
Aye.
Any opposed?
Move on to pass as amended.
Motion is ought to pass as amended. All those in favor say aye.
Aye.
Any opposed?
Consent.
Senator Abar moves consent.
Second.
Senator Prentice seconds. All those in favor say aye.
Aye.
Any opposed? And Senator Bernard will take it out. He did say he would. He whispered in my ear.
Oh. He was with me.
I know. Let's see. Senator Avard and Senator Birdsell were not here for 456. I don't know if you want to wait till the hearing report comes out on that.
Was there any issues with it?
That's the establishment of a Commission on Children's Futures. There was no opposition. HHS did point out there are a number of commissions that kind of do similar things with some overlap, but not entirely. Senator Prentice.
Thank you, Chair Rushford. So, I'm not in opposition. I just want to offer a comment, and I could talk about this with the sponsor, because it does talk about, in their charge, looking at IEPs, which is under special education. And I'm just trying to make sure within the members of the commission, now it does say teacher certified by the Department of Education, that we make sure that, teacher certified by the Department of Education, and it doesn't have to be just one, because there's 17 members here, but one of the teachers or somebody in here is a special education professional. I think that would be helpful to carry this a little bit, to target that, so it could be one teacher and a special education educator.
Okay.
And then I
We
just
can
want
do it. We can do it. We could do a committee amendment to
good, and
And what are we supposed to have?
just add teacher certified by the Department of Education with one specializing in IEPs.
we want to say with one specializing in special education, because IEPs could be five.
Yeah.
Yeah.
Could expand, so what Senator Birdsell said, and with just, I don't know, because it says, it's almost like, special education specializes, or one with a, certification or subject.
Yeah, with one who is certified in special ed.
Okay,
I mean, you're on education. I don't know how, I think that's how it's worded, correct?
yeah. Just
So
wanna
do
make
you
sure-
have that?
So we don't have a motion yet.
We don't have, no, just, okay, hang on just one second, let me quickly look and make sure. And, I'm sorry, Senator Bard, I just want to be.
I was supposed to have an amendment for your bill today.
Yeah, I thought I signed off on that.
I don't know where it is. Okay.
Okay.
It had to do with,
Should be good. So we'll take.
She's listening. That's
Oh,
She's like, yeah.
yeah, see what we can get up to.
That's, and that.
Mm,
We have next week.
all right. Oh, wait.
So 456, do we want to move that at this point?
Just looking up the certification issue
Okay.
and make sure I'm okay while we're.
Yeah, also on page one, Mr. Chair, number 8, state legislators. There's already appointed,
Yeah.
2 senates, 2 House of Representatives.
Yeah, I think we can get rid of 8.
Okay.
We've got John here. John, do you want to add something?
Yeah, you look like you're chomping at the
Move
bit.
to the front row, I noticed.
Senator Rocher, thank you very much for the body language signal. We actually had a conversation with Senator Sullivan just prior to the hearing, and we were suggesting, because of the fact that we report to so many different entities that are out there, having one more for us to report to is not overly helpful, but we certainly acknowledge the areas that she was looking to address and collect data. So the suggestion was that an amendment may be in the offering for consolidating this under an existing entity such as the Oversight Commission on Children's Services, to have them create a permanent subcommittee. Again, I'll stress that because the underlying bill is a permanent commission that she's being brought forward, that it would ideally be a permanent subcommittee within that entity to collecting information and then warehousing those items that might not already be under the charge of that specific commission, because it is an incredibly important but broad scope of things that she brought forward, everything from housing services to gang violence to children's behavioral health. And so we did have that conversation, and I know that she was having Declan look into models such as the permanent subcommittee under HHS oversight as it relates to Alzheimer's and related dementia. As we know, there are examples out there for that. So I would just respectfully ask you if you would just hold off potentially for a week to have a conversation with Senator Sullivan. If she has a different perspective, certainly we will defer to that, but still make the strong suggestion that using an existing entity makes much more sense than creating a brand new one that we'll all have to now report to.
You don't have to ask me twice. We're gonna hold off on this. All right.
Okay, so, and yes, they have to be licensed or certified. Certified is what we.
Okay.
Want to be
Good job, John.
clear.
Quick conversation on 520 that we just heard. This is, I think, I don't think you were here, Senator Abart, but this is Senator Reardon's bill that it addresses breast surgeries for minors, which she brought up I think, in my opinion, oversight in our legislation that we passed last year. And I thought we did this, and I don't know if it came out in a committee or conference or not. But at hand was there are medical needs where minors need a breast reduction. And I've got family members as minors that have had issues related to this. And, the ask in the bill isn't to undo what we did last year as it relates to transgender surgery, but add a little clarity to cases where, the minor isn't, trying to transition. They're not trying to change their gender, but there may be cases where there might be an orthopedic, postural, et cetera, issue where a surgery may actually be, in my personal case, I mean, I had a family member who was certainly not going down this road, and as a result, she could sleep at night and participate in sports and have a normal teenage years. So she had brought over some more language as a potential amendment, and if you look at that, one of the ones was.
Where's the amendment?
It's not an official amendment. She brought it forward in as a draft. Here it is right here. So there's two options that she presented. One would be after the bolded language on letter F. It would say, the total thing would say, at the election of the minor in consultation with her primary care physician, when the primary reason for breast surgery reduction is, but not limited to, mucoskeletal pain, postural changes, or physical discomfort of the individual that restricts exercise and activity. That's one option.
They're not limited to. Does that just still keep it open? If we got rid of that, would that, yeah,
You want to come up? Yeah.
would that put a monkey wrench in it?
Thank you, Senator Abard, for the question. I think the important distinction here is a fact that comes even before we get to those words about this is a breast reduction surgery for these. It's not a mastectomy. And And if that's clear in the bill, I think instead of trying to anticipate every possible symptom that this adolescent girl would have, this is a simpler way to do that. And again,
God forbid it'd be cancer.
I can't emphasize how much physicians rely on staying on the right side of the law and not tiptoeing if it's not provided for in the words.
I can accept this language.
Well, here's the other language, which is the next thing right underneath there. We could, rather than call out the specific things, she also floated this option. At the election of the minor in consultation with her primary care physician deemed medically necessary, unrelated to gender dysphoria.
Can we add this to that as well?
What?
Have them both combined?
Yeah.
I know that, but just to clearly spell it out. I like the first, the longer definition. Better.
Personally, I do too, but I'm willing to, I'm not baked in on that. I'm willing to have that discussion. Senator Prentice, did you have something you want to say?
I'm only baked into providing the clarity, like extra layer to protect the minors that, you know, want to have this done and their families agree. Because if they weren't a minor, it would be a non-issue. And we give the physicians the clear road to do what they need to do in these cases.
And I'm going to actually ask Senator Reardon. Senator Abard wasn't here for the testimony, and I hate to ask you to repeat your testimony, but specifically on the differences between the two, how it might play into that, and so he can give the full picture. You turn their microphone on.
My apologies. I provided the story of my constituent here that I was bringing this legislation on behalf of. And she was a high school girl that was, you know, trying to be invisible in the world because of how she appeared, and went on to become a very, very successful participant. She was in the Air Force. She received awards. She says she literally blossomed. She became a runner. She could not have even done jumping jacks in the Air Force before this time. So for her, when she read HB 712 from last year, this is the exact email that she sent to me that started this conversation. So really a life-changing event for her. And I think, as Chairman Rochford said, and I know personally the other people who this becomes a life-changing event for. So totally, I understand you're wanting to put the second part in here too, but we're trying to address the medical complications of what's happening here.
So when the primary reason, that whole language, would that work just as well? I just like that definition better. Top part, better than
The top one.
Yeah.
I personally do too.
But what is the will of the committee?
You like the top one as well? All right.
Senator Burton?
I'm good.
All right, I'm going to move on to pass on Senate Bill 520.
Second. And I would like to add a committee amendment.
Senator, did you get the motion? All right.
So on, I guess, in bold where it says F on the amendment, do I have to do the amendment? Yeah.
Yeah, you were.
Make a committee amendment, so on line F, I guess it would be. At the election of the minor in consultation with the primary care physician, quote, when the primary reason for the breast reduction surgery is, but not limited to, musculoskeletal pain, postural changes, or physical discomfort of the individual that restricts the exercise and activity. As a committee amendment.
Yes.
Yeah.
And I'll second that. And if you could just read that back to us, Sophie.
Letter F will be at the election of the minor institution with her primary care physician when the primary reason for the breast reduction surgery is, but not limited to, musculoskeletal pain, swallowing changes, or physical discomfort of the individual that restricts exercise.
Perfect. Any further discussion? All right, the vote on the committee amendment. All those in favor say aye.
Aye.
Any opposed?
Move on to pass as amended.
Senator Avard moves on to pass the amendment. And Senator Bertzel seconds. All those in favor say aye.
Aye. Aye.
Opposed?
And I have an amendment to 613.
So let's move consent. I'll move consent.
Second.
All those in favor say aye.
Aye.
Opposed? And Senator Bertzel will take that out. You're welcome.
There is that amendment for 613.
Okay.
We got it.
Yes. It has the correct language.
I passed it over that way.
Oh, the rest is here.
So 613.
Not behind.
Oops, oh, I'm sorry, Sophie. I didn't mean to.
So I move on to pass on 613. Yes.
Yes. Second.
613. All right, I got it.
And I would like to offer amendment 1161.
I'll second that.
Okay. And the amendment, basically, it has to do with the freestanding. Yep.
Hold on. Procedurally, and maybe I'm out here. Do we have, I think we have to deal with 613 first.
I did.
and then-
A motion to.
Oh, you motioned in?
Yep.
Pass it? All right. We're having a second.
And it was-
I'll stop having my side conversations and get it.
And we confirmed that is true. We moved on. All right, all right. And Sophie did validate, she confirmed that was.
And I offer amendment 1161. And speak to my amendment. Basically, this amendment is for the purpose of to protect patient safety and continuity of care by ensuring the transfer from freestanding hospital emergency facilities are based on clinical appropriateness with the patient's needs and regional access to hospital services. In essence, basically what this amendment is trying to do is just to make sure that these freestanding emergency rooms are agnostic as to where they go. So, for instance, you have a half dozen individuals that come to the emergency room that day, and 6 of them have insurance and 6 don't. And this way, they can't just grab the cream of the crop. They have to be somewhat agnostic on, is there a problem?
The amendment was drafted by OLS as a replace all, so it wipes out the underlying bill by accident.
It was.
Can we make that committee amendment change?
Yeah, this is to be added to it rather than a replace all.
I think that should be fine.
Good catch.
Yeah, that is a good catch.
Yeah. I would like to amend the amendment to remove the language of replace all.
Do you want to adopt the amendment and move a separate committee amendment so that it's not
What?
replace all, or you can adopt it as one big committee?
One big committee amendment, that way we don't have to undo what Senator Prentice's bill, because we just voted yes on it.
Okay, so I think that we would just want to withdraw the motion on the number itself and then just.
Okay, I withdraw my motion on the committee amendment,
I'll second that.
and then want to adopt the language on the committee amendment that I opposed without the language of amend the bill by replacing all but every bit of the language following that after.
Yeah, so it would be amendment 1161S plus the original underlying bill.
Yeah.
Okay.
And the idea is for the, so that these freestanding emergency rooms basically are agnostic, and so that they don't move those with insurance to one particular place and those to another place that do not have the insurance, making that burden on other hospitals. So this basically makes them agnostic as to the appropriateness of where the patient wants to go and the relatively close to whatever hospital they're at, rather than shipping the cream of the crop to one hospital so that they can benefit, without having financial difficulties, and the other ones have to just,
So just so I understand this, so let's say, just put it in simple terms, Maine Med opens up a freestanding ER in Littleton. This would prevent them from from automatically shipping all their patients to Maine Med when we have a hospital right down the street. Okay.
So, yes,
In the way on, we address this in two ways, so page 2, line 12. So it's in section 4.
Yep.
But this stuff, let's say, to Senator Rochefort's example, so Maymed has a freestanding center. It aligns the EMS statute because the emergency medical services statute says patients go to the closest place in the shortest practical time. But it also says, unless they want it, they can make a choice unless it's medically contraindicated. So if somebody wanted to go to Maine Med and they were stable and could, they could do it, but it isn't their choice.
Okay.
And it doesn't bind the ambulances to have to take some like way out of state trip or.
Yep.
So it aligns it with state statute that's already in place.
All right.
One change I made to the original amendment.
yes, and it makes sense. Makes absolute sense.
All right.
So, and thank you for allowing me to do this.
Yeah, and I thank you for, working and talking about it. I know it's late in the game, so.
Yeah, and I have to apologize because this was on my desk. I did give the updated language and I just didn't, I dropped the ball and moved into OLS, so it was my fault.
It's not that you're busy.
I just wanted to be clear. But I'm glad we're done.
We got a week to spare.
Oh, thank you, Senator.
All right, so. So any further discussion on the amendment? Senator Long?
Quickly, if I may, thank you. Should we, on the original bill, should we delete line 12?
On the original bill or the amendment?
On the original bill, line 12. Because we're adding this afterwards and it does have the effective date at the end of the amendment.
Oh. Well, we could,
Doesn't matter.
I think what would happen is that part would be effective immediately and then the second part would be.
Yeah.
Oh, okay. Oh, okay. All right. Perfect.
Okay.
All right, any further discussion on the amendment? And we're all clear on the amendment? We're not doing a replace all? Okay. So all those in favor of the amendment, say aye.
Aye.
Any opposed? All right.
Consent?
Oh, we got to vote on the bill. I have to pass as
Move on
amended.
to pass as amended.
And then I think we've got a second, Senator Prentice, right? Originally.
Original. Second,
Yes.
one for original motion. Thank you.
So on the bill, I to pass as amended, all those in favor say aye.
Aye.
Any opposed? I'll move consent. I have a second.
Second.
All those in favor say aye.
Aye.
Opposed? All right, Senator Prentice, this is your bill, the underlying bill, so you get to take it out.
And I want to thank Marie for getting that to me. Thank you, Marie, because I know you're watching. And I appreciate it.
Thank you, Marie.
Okay, that leaves, the only thing we don't have exec at this point are the two bills, my bills, from today. And we'll get those next week. And before we break for the day, that is the last of the Senate bills in Senate HHS. It was a challenging Senate side of the year, but we got it done and on time. So I want to thank you all for all the hard work and getting a very busy schedule done. So thank you very much. And with that, I'll take a motion to come out of executive session.
So moved.
Second, all those in favor say aye.
Aye.
Any opposed? With that, with the business of the day concluded, we are adjourned.
Let's go to lunch before they get down there.
Oh, yeah, that's great. Yeah.
The salad bar is fresh.